Hello, friends. I wanted to discuss with you briefly today a couple of issues. One related to testing, a review of testing for COVID-19. And towards the end, very briefly, I'm going to give you an update as a bonus on the severity of the COVID-19 Omicron variant in South Africa. There's some encouraging news from there. First, though, let's look at testing. When we talk about testing for COVID, we have to remember briefly here, and this is a graph from an article that was published recently in the scientific journal The Lancet. And we have to remember the natural history, the natural progression of this viral disease. First, you have the virus multiplying in the body of the infected person from a level that is very low here, and over the course, especially with Omicron now, and even Delta, over a very short period of time, it spikes up, in this parabolic fashion here, from a level of, maybe 100 copies of virus initially per ml of blood or nasopharyngeal secretion, but this is viral load measured in bloodstream usually, all the way to 10 to the power of the 10th. This is a huge increase over a short period of time. And after that, as time goes on and the immune system starts to kick in a few days later in here and suppress the virus, you see this massive drop to almost nothing. But it can take 7, 14, sometimes 3 weeks before the virus is completely clear from the person's body. As this happens, and there's a threshold here of what is called infectiousness. Over this level, the person is contagious. It can give it to somebody else. And so you see that first week is critical for most people who get infected, especially those who are not vaccinated or who haven't had COVID before and they are immune naive. Because as you see here, the immune system starts to pick up speed, and only about 2 weeks into it, for somebody who's not vaccinated or previously infected, the immune system and the antibody level increases enough to where it suppresses the amount of virus to low enough levels. But the other thing I wanted to show you here, and that's important for testing, is that when we talk about the viral load, the spike in virus here that we discussed earlier, there is a time frame, usually within the first week of infection, where we can find antigen, that is, the components of the virus can be found and easily testing from nasopharyngeal swabs or oropharyngeal swabs typically, and that's when that rapid test can be done. The PCR test, which looks at the genetic material of the virus, can detect the virus earlier on, because you see here, before the antigen becomes detectable, the virus is still present during this initial phase here. And later on, as the antibody levels, whether it's immediate infection type antibodies of type M or longer term memory antibodies, IgG, these are the basis of immunological testing, antibody testing, to see if you had infection. But let's go to the actual test options here. And this infographic summarizes the three types of tests. You have the PCR tests, you have the antigen tests, and you have the antibody or serology tests. And as I just suggested earlier on, and this repeats some of that information here, this first molecular test, the PCR, the genetic amplification test, it's the most sensitive, the earliest, and the most specific. So it has a number of advantages. It shows up positive the first. It's very specific of COVID-19. There is few cases of false positive or false negative, so it's very accurate. The disadvantage of this test, of course, is that it takes a little time to get the results. It's not instant. It could be a day or two, depending on where the testing is done. It requires a specialized lab and instrumentation. It's expensive. I remember at our hospital, it took a few months before they got a really, early in the pandemic, a really good, fast machine that could provide test results right away or within a 20-hour time frame. Antigen tests, in the United States here, the president announced that 500 million tests will be available for free to people living here. Other places are trying to do the same thing. Those antigen tests, what they do is they are only able to be to detect the infection once the number or the threshold or the viral load went over this threshold. So early on, the test can be negative and somebody can still be in the early phases of the disease. And the same is true later on after a certain time when the virus concentration dropped below that threshold, the antigen test is no longer positive. But the advantages here is cheap. The results are very quick, almost instant. It's almost like a pregnancy test. You can do it at home. It's easy to scale up. And so this is a distinct advantage. And finally, the antibody tests. I have patients who come and this is a scenario that we oftentimes do this test, is somebody comes and said, doc, I was so sick early in the pandemic, I never went to get tested, or even before COVID testing was available. And I want to know, did I get COVID or not? And they are not vaccinated. We used to have these discussions a lot more earlier in the pandemic where people were on the fence. Should I get vaccinated? What if I already had it and I didn't even have much symptoms? We know there are some asymptomatic cases and so forth. So in those cases, we can do these serological, these antibody tests where we measure their blood antibodies. And that can be done. It's fairly simple to do. It takes a few days, so it's not as fast. But this is a retrospective. This tells you if you had the infection in the past. It doesn't tell you if you have the infection right now, because as you remember, the antibodies start to go up a week or more into the infection after you've been infected and sick with COVID. So this is not a test you want to do to detect if you have the infection now. It's a retrospective test to see if you had it in the past. The other thing that can plague this test, because there are many coronaviruses in addition to SARS-CoV-2, you can run into false positives. So you get the test, but sometimes it tells you that you had another coronavirus, not necessarily the SARS-CoV-2, and it can provide some false reassurance and things like that. So this is basically the main, the three main studies or tests that can be done to determine if somebody has COVID. And as I promised you in the beginning, I wanted to show you here very briefly an update on the severity of the Omicron infection in South Africa. This is a study that was published just today. It's a preprint, so it hasn't been peer reviewed, so we have to remember that. But these guys, I feel, in South Africa, they have a pretty good track record, both recently and before, both in terms of very advanced testing capabilities and good science coming out of that. Really good epidemiologists and statisticians and infectious disease docs. And so the studies there are usually very good quality. And so what did they do? These guys, they tried to determine how severe the Omicron variant is. They had a bunch of Omicron showing up in November, to the point that by early December, the vast majority of infections there, new cases, were with Omicron. And in order to determine and compare severity, they went about by doing a very interesting test. They separated the test results for COVID during that interval by looking at test results that they called S-gene target failure. This is a proxy for Omicron, basically. So whenever a test came back showing this type of result, it meant Omicron. And those that were non-SGTF were Delta or some other variant, but Delta was really the only variant. So they compared these Omicron tests with those that were non-Omicron, basically. And then they looked into the database of hospitalizations, how many people ended up in the hospital, and also how severe those cases were once they were hospitalized. And to make the story short, this is the interval they did this. You can pause the video if you want and read the whole thing here. But I think the important thing that we want to remember from this studies, and again, it's preliminary, it's early, but it's the best we have, and it is encouraging. What it shows is that compared to earlier Delta infections, and after they control for a bunch of things, people with Omicron, this SGTF, people with Omicron had lower odds of severe disease. And here they have an adjusted odds ratio. It's a statistical term, but of 0.3. What that means is that the severity, in simple, plain language, with the risk of oversimplification, but just so it makes sense, is that the severity of Omicron compared to Delta was only about 30%, with a range of 20 to 50%. You see those numbers in parentheses over here, the confidence interval. So this is really good news. If this plays out, and it seems like it will, data from Great Britain appears to indicate early on that hospitalization cases are not really tracking up as high as new cases. So if that's maintained, this will also be replicating, hopefully, this data here. As I said in my earlier video from today, though, we don't have to be complacent, because even a rate of severity that's only 30% of Delta in a variant that's 5 times more contagious than Delta, it's going to still be problematic and can easily overwhelm the health system of any country. In any case, I hope this is going to be helpful and useful to you. As always, you guys stay healthy and stay wise, and we'll talk some